My name is Khalil.
Admittedly.
Hello, everyone. Thank you for joining us on this evening for the fourth week of the summer lecture series with RRIPG. Tonight, we will be starting our lecture series with our featured speaker, Dr. Jonathan Weinstein, who is an interventional cardiologist and the managing partner at North Suffolk Cardiology in Stony Brook University Hospital, Department of Medicine. I'd also specifically like to introduce everyone in our conference call. Dr. Weinstein, feel free to start whenever you'd like. I'll be pulling up your presentation now.
Thank you so much, and thank you for allowing me the opportunity to be here with you tonight. I'd like to thank Dr. Lopez and the Rugby Research and Injury Prevention Group for providing me this opportunity to talk to you guys tonight on myocarditis secondary to COVID and the concerns in the athlete. Hopefully this talk is going to update everybody regarding the rare incidence of myocarditis in the population and even smaller incidents among athletes. Additionally, I'd like to thank the affiliates of RRIPG, the Hospital for Special Surgery, the Auckland University of Technology, the National Operating Committee on Standards for Athletic Equipment, and the local rugby unions for their support of RRIPG. So as we said a couple of minutes ago, we're going to be talking about myocarditis secondary to COVID-19 and the concerns in the athlete. We can go to the first slide. So what is myocarditis? Myocarditis is inflammation of the heart muscle, which is also called the myocardium. Myocarditis can affect the heart muscle and the conduction system of the heart, leading to arrhythmias and sudden cardiac death. The symptoms of myocarditis could be chest discomfort, shortness of breath, palpitations, feeling any kind of irregularity in your heartbeat. We can go to the next slide. The diagnosis of myocarditis is a clinical diagnosis. There's really no definitive test for it, but there's a whole bunch of tests that we can do that give us the idea that it's happening. Initially, the first test that we would do in the workup for myocarditis is a simple 12-lead EKG. The EKG is basically a basic test that's going to show the electrical activity of the heart, especially the rhythm. The most typical sign of myocarditis on an EKG is sinus tachycardia, which is a normal rhythm with a fast heartbeat. Sometimes on non-invasive imaging like a chest x-ray, you can see that the heart can be enlarged, or maybe there is a suspicion of fluid around the heart, which could be indicative of a diagnosis of myocarditis. An echocardiogram would also be an upfront test that we would do. An echocardiogram is a sonogram of the heart, which is, a test that helps us look at the structure and the function. We want to see the 4 chambers of the heart, the 4 valves of the heart. We want to make sure that the muscle is squeezing well and relaxing well. And in myocarditis, you can have either a focal abnormality in the wall motion or a diffuse, weakness of the heart muscle. Blood tests can be helpful in myocarditis. There's different blood tests that we'll use, a CPK level, which is a muscle enzyme, or a troponin level. These enzymes would not normally be found in circulating blood unless there was active injury going on to the heart muscle. So if we see these enzymes in the blood, that is, an indication that there is heart muscle injury, which could be, used to help make the diagnosis of myocarditis. One of the best tests that we have for myocarditis is the cardiac MRI. And obviously with more increasing availability, this is a test that is being used more and more. As you can imagine, imaging the heart is unlike imaging any other organ in your body, because unlike any other organ in your body, the heart can't stop for the pictures. So the amount of detectors on scanners had to be increased for, before we can get really good pictures to show us any information about the heart. But just like echocardiography or other non-invasive imaging, we can assess heart size, we can assess heart function, we can assess valvular competency, during an MRI. And what an MRI is really good at showing us is scar. And that we'll see in some of the pictures that we have. We can go on to the next slide. So, there's 2 different types of myocarditis. There's an acute form and there's a chronic recurring form. Obviously, myocarditis in certain cases could be subtle. It could even be, something that people didn't understand that they had, but in other cases, it could be severe and it could lead to cardiogenic shock, which is the inability of the heart to keep up with the demands of the body. And it could also lead to arrhythmias, which could lead to sudden death. A lot of times with myocarditis, there's resolution of the heart muscle function, but sometimes after myocarditis, the heart muscle remains dilated and weak, and that can have long-term consequences like chronic systolic heart failure, or what we call heart failure with reduced ejection fraction. Sometimes with myocarditis, it can be so aggressive, it requires mechanical support, like extracorporeal mechanical oxygenation or ECMO, and it can require, a transplant. So we can go to the next slide. So acute myocarditis associated with COVID-19 infection. A clinical case here is a 20-year-old male with no previous cardiac disease, had a positive COVID-19 nasopharyngeal swab, came with elevated blood pressure, an elevated heart rate of 111, elevated troponin levels, elevated CPK levels, specifically the MB fraction, an elevated pro-BNP level, which is a sign of congestive heart failure or strain on the heart, and an elevated C-reactive protein level, which is basically an inflammatory marker. The next slide shows cardiac MRI, imaging of the heart. And what we see a lot of times, you can see, is that there's delayed hyperenhancement. There's this ring of scar on the lateral wall, this white, if you look in the middle picture, where those arrows are pointing, you see that white ring, which is scar. And, that's one of the findings that the MRI is really helpful in allowing us to make the diagnosis of myocarditis. So that delayed hyperenhancement is usually, like I said before, it's a sign of myocardial injury, scar, and sometimes there's associated edema with that signal. So we can go on to the next slide. So, talking about the etiology of myocarditis, viral infection is the most common cause of myocarditis in Western Europe and Northern America. It's usually caused by the adenoviruses and enteroviruses, just the common cold. With the MERS, Middle Eastern respiratory syndrome, there was acute or fulminant myocarditis associated with that virus. Tachyarrhythmias and symptoms of heart failure could be associated with the SARS beta coronavirus. Due to similar pathogenicity, COVID-19 infection could be expected to have similar cardiac effects as the above viruses. Direct viral injury and cardiac damage due to the body's immune response are the proposed mechanisms of how COVID-19 myocarditis can cause issues with the heart. We can go on to the next slide. So the CDC recently acknowledged that there was a correlation between the mRNA vaccines and the onset of myocarditis in the adolescent and young adult population. There were some reports, although they were few, they were higher than what would be expected in that age population of individuals. The Israeli Ministry of Health reported that 27 cases of myocarditis followed the first 5.4 million vaccine doses, and 121 cases of myocarditis followed 5 million second dose administrations. So the incidence of myocarditis in the vaccine, related population, it's usually in young men aged 16 to 19. In the sports world, there were a few recent, high-profile cases where athletes had witnessed sudden cardiac death. Specifically, the case of Keontae Johnson, who was a basketball player at the University of Florida. He collapsed during a basketball game, and thank God there was a cardiologist sitting in the front row who was able to resuscitate him. The concern was that he had myocarditis related to COVID, but my understanding is, to this point, they're not really sure that that was the cause, but it would definitely make sense that someone who had a viral myocarditis and a severely weak heart, who's an athlete, could potentially have a tachyarrhythmia-induced, episode. So, moving down to the next slide, the importance of cardiac MRI. So, myocarditis was unfortunately diagnosed in Demi Washington at Vanderbilt University women's basketball player after a mild case of COVID-19. The cardiac MRI was mandated by the university before they would allow her to play, and it was the only test that helped corroborate the diagnosis of myocarditis. And having that information and delaying the athlete from resuming high-intensity activity could have potentially saved her life. Myocarditis is the leading cause of sudden death in competitive athletes. There is a 1 in 50,000 incidence in collegiate athletes. 1,597 athletes spanning 13 universities underwent cardiovascular testing after COVID-19 infection. 37 were diagnosed with myocarditis following cardiac MRI, where only 5 would have been diagnosed based on their symptoms and history. The more recent high-profile case of an athlete was Christian Eriksen, the best soccer player in Denmark, collapsed in the first game of the season against Finland. He required CPR and an AED. They again, to my understanding, they're not yet sure that this was related to COVID, but it just goes to show that young athletes, no matter how well conditioned, are not immune to arrhythmias and sudden death. This certainly could have been due to a COVID infection if they can, prove that he had antibodies or some prior infection, but it's unsure whether or not he had that or had the vaccination. So again, going down to the next slide. COVID-19 related myocarditis, future care in elite athletes. So, basically talking about treatment for COVID-19 myocarditis briefly, there are multiple different treatments. There's the steroids that we sometimes give people, like methylprednisone, which suppresses inflammation in the body, which is one of the causes of muscle injury. There's an entity called pericarditis, which is very similar to myocarditis in terms of history, physical symptoms, but pericarditis is inflammation of the sac that holds the heart, called the pericardium, and myocarditis is an actual problem with the heart. You would never first line give steroids to someone for pericarditis because it increases the chance of recurrence, but in myocarditis, steroids are actually more appropriate. Conversely, in pericarditis, you would think about giving non-steroidal anti-inflammatory drugs like, Advil, Motrin, Aleve in high doses. But for someone who has myocarditis and a weakened heart muscle, the non-steroidal anti-inflammatory drugs actually, they cause poor outcomes because of everything with the heart failure. Sometimes in cases that are severe enough, we'll give immunoglobulin. If someone is in cardiogenic shock or in congestive heart failure, we might give medications like diuretics to get rid of the extra fluid. Heart failure begets heart failure, so the more fluid someone's retaining, the worse the heart is going to perform. So helping diurese someone with an IV water pill is potentially going to help them. A lot of times we'll use inotropes, medications like milrinone, dobutamine. Those help the heart muscle squeeze a little bit better when it's weakened, and those can improve the cardiac output. Prior to anybody returning to their sports, there should be some, physician input, and a resting echocardiogram, meaning not a stress echocardiogram, could help show the structure and function of the heart again, maybe help prove that there's restoration of normal left ventricular function after an infection. Heart monitors could be used. We have 24-hour heart monitors to look for abnormal heart rhythms. If someone has a lot of extra heartbeats, whether they be atrial premature contractions or ventricular premature contractions, that could speak to the activity of the inflammation in your body. So if you have a Holter monitor that shows a lot of arrhythmias, that could potentially show that we're not ready yet to resume regular activity. And then, before clearing someone, it would not be unreasonable to do an exercise treadmill stress test to basically prove that someone can get to a certain amount of metabolic activity without having heart failure or rhythm disturbances that are going to make it dangerous for that person to return to full activity levels. And obviously, at some point, as cardiac MRI becomes more and more prevalent, there is probably going to be a role for cardiac MRI, in following these patients up in the future and making a statement about how much inflammation there is and how safe it would be for that athlete to return to full activity. So that's about all I have to say on myocarditis, but if you guys have any questions, be happy to entertain them.
Thank you so much, Dr. Weinstein. We really appreciate your time. Again, I would just like to follow that up if anyone has any questions, or if Dr. Lopez, you'd like to add anything yourself. We'll now open the floor.
Good evening, Dr. Weinstein. My name is Obafemi Michael. You mentioned that stenosis and scarring is part of diagnosing myocarditis. Is there any treatment to reduce the scarring or that leads to the athlete or patient going back into activity?
Yeah, so actually, great question. Thank you so much. So basically, when there's evidence of scar in the heart, scar is usually permanent. That is suggesting a permanent injury, but it may not have an actual effect on the overall performance of the heart. So a lot of times when people have coronary artery disease and have a subendocardial infarction, they're not having a full thickness infarct. So it's kind of like burning a little rubber off the tire. Yes, you'll kill a couple myocytes, there'll be a little bit of a scar, but overall the performance of the heart will not be impaired. The neurohormonal medications that we use to treat heart failure, like the ACE inhibitors, angiotensin receptor blockers, and novel medications like Entresto, those medicines actually help decrease the scar formation and remodeling that happens after a heart muscle is injured. So a lot of times if we see injury on a heart muscle, we'll put people on an ACE inhibitor, an angiotensin receptor blocker, because that might help. In terms of stopping the active injury to the heart muscle, unfortunately, this is usually a process that we have very little influence over. The viral infection runs its course, and we're kind of left to pick up the pieces afterwards.
Thank you.
I had a question as well. I was wondering, I know this topic was with reference to an athlete or collegiate athlete, but what are the risks of myocarditis in just an everyday person who is an avid runner or avid workout class attendee? Are these risks of myocarditis still as high, or is it due to the elite stress training of an athlete specifically?
Yeah, so it's really not the myocarditis in and of itself. The athlete is not more predisposed to it, but if you have myocarditis, I don't think I said this during the talk, but when you have myocarditis or pericarditis, one of the most important things to do to get through the infection is to rest, okay, and not stress the heart. So keeping the heart rate down and taking the stress off the heart and not bombarding the heart with stress hormones that are circulating through your body. Those are the things that are going to make it safer. But when you have someone who has a subclinical infection, who does not know that their heart muscle is inflamed or injured, and then they go out and they do these extensive, activities, and their stress hormones are surging, that is a pro-arrhythmic state that leads to someone having a dangerous heart rhythm. And that's really, I think, why the elite athlete is more susceptible to the bad outcomes that we see.
Thank you.
Sure.
I also have a question, if you don't mind. I was reading a little bit, and it mentions occasionally that athletes sometimes have adaptive fibrotic scarring, but that's also a characteristic of myocarditis. So are there cases or times where those two will need to be differentiated between?
Yeah, so another fantastic question. I'm sorry if I cut you off a little bit early. I just get excited when people ask questions. But sometimes, like I said before, this is a clinical diagnosis. And, as they said before, I'm an interventional cardiologist, so I'm doing invasive procedures on the heart. I do angiography, I do valve replacements, angioplasties, but a rare procedure I do is a cardiac biopsy. And when there is an injury to the heart muscle and we're not really sure what the etiology of the injury is this, why is someone doing so poorly and getting worse despite treatment? We will do a biopsy, and that biopsy sometimes allows for the differentiation of what caused the injury. Now, what makes my job easier, but unfortunately might not be a satisfying answer, is it almost doesn't matter what causes the injury to the heart muscle. All heart muscle injuries are treated the same way. The consequences of an injured heart muscle are heart failure and abnormal heart rhythms. So like the first question asked about treatments, you would put someone on an ACE inhibitor, you would put someone on an angiotensin receptor blocker, you would potentially put them on a diuretic, and you would monitor them for arrhythmias, and that would be the treatment for any scar in the heart. You wouldn't necessarily need to know that it happened from this reason versus that reason. The only time that becomes important is when it's something that's an ongoing exposure. So if someone has a toxicity that's affecting the heart muscle, like a chemotherapeutic agent causing, a cardiomyopathy, or an environmental exposure, or an underactive thyroid. If there's some kind of ongoing injury to the heart muscle, you'd want to know what that is so you can stop the ongoing injury to the heart muscle. But in terms of which virus, and if it was done from, the high intensity athletics, it almost doesn't matter. Once there's an injury, you treat it just like you would treat it if it was a heart attack from a blocked artery. Lower the blood pressure. The heart will work better if you lower the blood pressure. Give someone a diuretic for volume overload. And then just, depending on the strength of the heart muscle, we usually cut off 35%, an ejection fraction, which is the estimation of the heart muscle strength. If the ejection fraction is less than 35%, those patients are at a highest risk for abnormal heart rhythms, and you might want to do something to protect them, like give them an external defibrillator to wear until their heart muscle is either improved, or implant them with a permanent defibrillator.
Thank you.
Sure.
And no more questions. Thank you again, Jonathan. I have one simple question, which would probably is a loaded question. And that is, obviously, with the low incidence of encountering myocarditis with the COVID, do you feel that COVID pre-seasonal testing will be applicable or find a place in preseason concerns for the athlete? Or do we just wait for symptomatology and then deal with that case on a case-by-case basis?
Yeah, I think that's a great question. And I think that, you hear this talked about all the time. Most of the reasons why young people collapse on a ball field is a congenital abnormality in the heart, a hypertrophic cardiomyopathy, a anomalous coronary artery origin, something to that effect. And there's always this talk about screening echocardiograms for competitive athletes. And not to get political, but there's no reason not to do it. It's a cheap test. There's no radiation exposure. It's reproducible. And I think that would be the safest and best way to monitor somebody, because as you and I both know, who knows if someone's going to make antibodies or not, or, are the antibodies still present? And people test positive for COVID way after they've had it. So I don't know that the antibody testing is the right way, but I think almost just a screening echocardiogram for all high intensity athletes is a great way to keep people safe.
I'll tell you just a little story. This is exactly what's occurring right now at the Olympic Development Academies. The centers are uncertain of how, when to appropriately screen, when they're going to screen, or how they should screen before sending the players over to the centers, and even prior to them deciding if they're going to be backup for the athletes in Tokyo. So it's an ongoing challenge and hurdle right now that everyone's kind of scrambling to try to really understand of how to apply and when to employ. And that's really, I guess, always the difficulty with high-level athletes and how much demand they put on their bodies. And I guess we can conclude on that point. And thank you, everyone. And thank you, Dr. Weinstein. Please get back to your patients in the operating room. And thank you for your time today.
Guys, thank you for Victor, Dr. Lopez. Thank you so much. Have a good night, everybody.